Welcome to Clinicals with PharmVic. Today I will be talking about eczema and its treatment. Eczema dermatitis includes a number of conditions characterized by skin inflammation and itching. Atopic eczema is the most common and most studied form, but principles of management are generally the same for all types. Rationale for drug use: to reduce signs and symptoms, to prevent recurrences. Before starting treatment, identify and, if possible, avoid potential triggers including irritants, for example, abrasive clothing, soaps, detergents, including bubble bath, raised temperatures, and sweating, allergens, for example, preservatives, fragrances, lanolin, nickel, aeroallergens like house dust mites, animal dander, foods, only avoid if confirmed by testing. House dust mites may worsen eczema in patients who are allergic to them. Reduction measures, for example, impermeable mattress covers, may be tried, but achieving low levels of mites is difficult and evidence that eczema is improved is conflicting. Consider referral to a dermatologist when antennas differ. Diagnosis is in doubt. Eczema is not controlled with topical treatment. Treatment with phototherapy or systemic agents is indicated. Secondary infections are recurrent. Treatment: moisturizers improve the skin's barrier function and reduce itching. They also increase the efficacy of topical corticosteroids, reducing the amount required. Moisturizers should be applied liberally at least twice daily, particularly after bathing, even when eczema is under control. And do it too. Although ointments are generally more effective than creams or lotions, choice often depends on patient preference. Do not use moisturizers that contain sodium lauryl sulfate, like aqueous cream emulsifying ointment, as they may worsen eczema by damaging the skin barrier and causing irritation. Bathing: use lukewarm water and emollient soap substitutes or fragrance-free bath oils. Minimize bathing time and always apply a moisturizer immediately afterwards, as moisturizers reduce water loss from the skin. In more severe cases, soaking in lukewarm water containing fragrance-free bath oil for 10-15 minutes once daily may help to hydrate skin and remove crusts and scales. Apply a moisturizer or topical corticosteroid immediately afterwards while the skin is still wet. Frequency can be increased to twice daily in acute flares, where it may be used before wet wraps, or decreased to a couple of times a week for maintenance. Topical corticosteroids: use corticosteroids to manage flares of eczema. Choose the potency and formulation based on disease severity, area and location, and the patient's age. Apply once daily, increase to twice daily if response is inadequate. To prevent flares if they are frequent, corticosteroids may be used 2 or 3 times a week or on 2 consecutive days per week. Topical calcineurin inhibitors may be a useful alternative to topical corticosteroids for patients who require treatment of sensitive areas, for example, face. Pimecrolimus appears to have similar efficacy to mild topical corticosteroids. Tacrolimus may be used if pimecrolimus is ineffective. Tacrolimus 0.1% ointment appears to be at least as effective as moderate corticosteroids. Crisaborole. Crisaborole may be used for mild to moderate eczema. However, its place in therapy is unknown, as there are no comparative trials with topical corticosteroids or calcineurin inhibitors. TARS. TARS may be useful for seborrheic dermatitis and chronic or lichenified lesions. However, there is limited evidence for their efficacy. Do not apply to acutely inflamed skin, face, flexures, or genitals because of the potential for irritation. Wet compresses and wraps. A wet compress, soaked in cool water containing plain bath oil, may be applied to the affected area for 5-10 minutes to relieve itch. Always apply a moisturizer after use. Wet wraps, dressings, soaked in tepid water containing plain bath oil, may be used to treat moderate to severe eczema when initial response to topical corticosteroids is inadequate. Techniques vary, but generally consist of a wet bottom layer and a dry top layer applied over a moisturizer and/or a topical corticosteroid. They may be left on overnight or, if used during the day, changed up to 4 times daily, since once dry, the dressings can cause irritation. Or inappropriate use or overuse may lead to folliculitis, infection, maceration, or excessive dryness. Do not use antiseptic bath oils for wet compresses and wraps, as they may cause contact dermatitis. Antihistamines. Short-term use of sedating antihistamines may be useful for patients with sleep disturbance due to excessive itching. Less sedating antihistamines are of little value. Antihistamines. Short-term use of sedating antihistamines may be useful for patients with sleep disturbance due to excessive itching. Less sedating antihistamines are of little value. Systemic immunosuppressants. In some cases, a short course of systemic corticosteroids may be used for severe acute flares. Although corticosteroids produce dramatic clinical improvement, they may be associated with rebound flaring after stopping. Avoid long-term use or use in children. Immunosuppressants may be used for patients with severe, chronic, disabling disease unresponsive to other treatment. Their use should be initiated and monitored by a specialist. Both cyclosporin and azathioprine are used, but adverse effects limit their use. Other immunosuppressants, like methotrexate, mycophenolate, have also been tried, but further studies are required to assess safety and efficacy. Phototherapy. Phototherapy, like UVB light, may be used by dermatologists for severe disease unresponsive to other treatment. Other treatments. Other treatments such as dupilumab and baricitinib may be used by specialists to treat moderate to severe eczema unresponsive to topical treatments. Types of eczema. Nappy dermatitis. To treat and prevent nappy dermatitis, change nappies frequently. Maximize nappy-free periods. Apply a barrier product containing zinc oxide, white soft paraffin, dimethicone with every nappy change. If other topical treatments are needed, apply barrier products last. Use highly absorbent disposable nappies, particularly when treating nappy dermatitis. If using cloth nappies, avoid using plastic pans. If inflammation is severe, causing discomfort, or is unresponsive to the above measures, hydrocortisone ointment can be used until it settles, usually 3 to 5 days. If candidal infection is suspected or confirmed, treat with a topical azole. Eyelid dermatitis are commonly caused by allergens and irritants. Moisturizers are safe to use. Use topical hydrocortisone on the eyelids with caution and for short periods only due to risk of adverse effects. Pimecrolimus may be used on the eyelids. Seborrheic dermatitis. In infants, seborrheic dermatitis of the scalp cradle cap resolves spontaneously within a few months. Use a baby shampoo regularly to loosen the scales. If necessary, soften scales first by applying an emollient, for example, baby oil, vegetable oil, white soft paraffin, and then remove with a soft brush. If it is severe or persistent, a short course of topical hydrocortisone or ketoconazole may be useful. In adults, seborrheic dermatitis is a chronic, relapsing condition. Topical products containing pyrithione zinc, coal tar, selenium sulfide, miconazole or ketoconazole are used. Shampoos may also be used on areas other than the scalp. For treatment, apply 2 or 3 times a week, daily if severe. To prevent relapse, weekly or fortnightly application may be useful. A short course of topical corticosteroid may be added to reduce inflammation and itch. Products containing salicylic acid and/or sulfur may be used to reduce scale. Practice points. Secondary infection often occurs and may be bacterial, usually S. aureus, viral, for example, herpes simplex, or fungal. Although probiotics and herbal and complementary medicines like evening primrose oil have been used in atopic eczema, there is no evidence that they are effective drugs used for eczema. Examples of corticosteroids for skin include betamethasone, clobetasol, clobetasone, desonide, hydrocortisone, methylprednisolone, mometasone, triamcinolone, fingertip units, Fingertip units can be used to measure the amount of topical corticosteroid to apply to an area of skin for adults and children. A fingertip unit is the amount of cream or ointment squeezed out of a tube with a standard 5mm nozzle from the tip of an adult's index finger to the first crease. One fingertip unit, approximately 500 mg, is generally enough to cover an area twice the size of a flat adult hand with the fingers together. Another classification of drugs used for eczema is tars. Examples include coal tar, ictamol, wood tars. If this lesson helped you, don't forget to hit that subscribe button. Society, please share this video. You never know who might need the right information to ace their exams or become more clinically sound. Let's grow together, learn, revise, and succeed.